Okay, so there was a gentleman in the blue shirt and then the lady in the dress there. Yeah, if you could say very briefly who you're from, because I think we've got quite a diverse audience and it'd be interesting for people to hear the different roles that you have.
My name is Samah Youssef. I'm from Crown Agents, and
Okay.
my question is about the GSK program and how the community health workers are being compensated for their time now, and how this will be sustained in the future, and whether there is any commitment from ministries of health to pay salaries to community health workers in the future. Thank you.
Okay, thank you. And then the lady behind you. There's a lady back there, kind of patterned black top.
Hi, I'm Biancas from SAB Miller. We're a brewer, not a healthcare provider, but there's some really interesting read across from these projects and some very interesting lessons around partnerships. So my question for Darryl is actually two. Laurie promised us some indications of what doesn't work, and so I'd love some candour on what maybe the biggest challenge you faced in building such complex partnerships were and how you address them. And then the second point was around advocacy and how do you really motivate people and demonstrate the value of advocacy and the responsibility? How do you allocate the responsibility for that? Because that's clearly a very important part of it, but perhaps less tangible for some of the actors.
Okay, and then we have one over here, please. And then we'll come to the panel. Oh. Yeah, we'll take the first three and then we'll have another round on the same topic.
My name is Ellie Brown and I'm from Options, and we run quite a few maternal health projects, and you know there's a lot of different approaches of working with the private sector in order to improve maternal health across our programs. One thing that we do is that we have facility level scorecards that measure the facility's preparedness for addressing maternal health. And just from our experience, lots of things have come out from that because it will measure quality of care across lots of different domains. But one thing that I would highlight is that, for example, when we look across different kinds of interventions that are aimed at a facility level, we often find that the vertical programs work very well. So in northern Nigeria, the immunisation programs work very well, but things like health workers availability is very low. But also things like infrastructure are very, very low. And I don't really understand how we can be saying to improve maternal health care if, for example, facilities don't have running water or electricity to run fridges and things like that. So I wanted to just ask about how you make decisions about improving infrastructure with the funding that you have, and just to talk through that a bit more.
Okay, thank you. So, Darryl, if you want to go first, then I'll come to Fiona and see if anybody else wants to.
Okay, so the first thing I'll talk about is the issue of compensation. So a huge challenge for community health, for access to health at the community level, are that many of the workers, whether they be volunteers or community health workers or health extension workers, some are paid and some are not paid. Some are recognised by the health system and paid. Some are recognised by the health system and not paid. So it's a huge challenge, actually. And I think that's why our programme isn't just about training. Really, really important that we address those issues because it varies from country to country. And the advocacy components of our programme and the capacity building both aim to address that issue. So we will always support where it's appropriate for the community health workers to be recognised and be compensated for their work if they're not at the moment. And our programmes do try and do that. So the advocacy component really tries to do that. And you know the lack of pay and career development for health workers is a big reason for attrition. They will often go elsewhere, whether it be from a rural community to a city or from a city to another country where they can be paid and recognised for their work. So it's a huge issue, and a lot of our work does focus on advocating for that recognition. However, in my observation actually on various visits, so that sounds like a huge issue, and it is definitely a big one. But a couple of things that we start to build in and that already exist are that some of the health workers, or many of the health workers, are also compensated in kind by the communities that they work with and derive a huge amount of pride in doing that role. So that does help it to stick better than you might think it would. I've just been to Burkina Faso with Save the Children on a visit there, and the community health workers there are not paid at the moment. They're trained and they're not paid. So we always think, I mean, there's an advocacy component to the programme which advocates that they do get paid, but they're not getting paid yet. The few health workers that we spoke to that are there are all very much committed to their work. They're supported in kind by the community and they take immense pride in what they do. So that compensates the lack of proper compensation to an extent, but it's a big issue. What we don't do in the GSK programme is we don't pay the health workers. We will support their training, we will work with the NGOs to ensure that they get up and running, but we don't want to be we don't think it's appropriate from a sustainability point of view for us to do that piece. The last bit on compensation, and that we see in the Bangladesh programme, is that by building entrepreneurial skills into the training of the health workers, we'll allow them to sell some of their services for a fee. That's of course done with the permission of the local and the central ministries of health. But those are some of the things that we can do to address that very important issue. But it's a huge huge issue in global health, so not one that we alone can crack. But hopefully our programmes are structured in the way that addresses that. The next question was on what doesn't work. Well, that actually follows very nicely. So I think one of the things I mean, I wouldn't say it doesn't work, but it's one of the things that's a challenge for us is indeed on making sure that the health workers that are trained and the systems that we put in place continue. And I'd say that issue of attrition of health workers is probably the thing that, if you want to call it that, is perhaps one that doesn't quite work. We hope that working through 3 very well-established partners, that there's a culture of continuous improvement and learning across the programme. So when issues do arise, we do attempt to address those either within country. So the excellence that's been delivered in the programme in Bangladesh is helping to address some of the challenges that CARE may find in some of the other programmes that they have. And equally, actually, and probably more impressively, we want to ensure that what CARE do very well is adopted by Save the Children, and what AMREF do very well is adopted by CARE. So I think that issue of continuous improvement helps us to continually learn. But I'd say probably the biggest thing that doesn't work, or that may not work, or that may have an impact on the programme is actually the issue of compensation. Are there any others?
There's this, how do you choose between spending on infrastructure versus human resources?
Yeah, and again, I think when the programme started, it was labelled as community or health worker training. And actually, I would say that in a total project, probably only 40 to 50% of the funding is being used to do training. We will work, and we're very flexible with our NGOs that we build around that, and that's that capacity building piece, whether that's equipping a training institution, whether that's strengthening a health facility, and so on. We are open to addressing some of the other aspects that go around and that wrap around that whole supply and demand piece around a programme. Now, of course, in any programme that you do, you can solve one issue and then the next one arises. So you can never completely do that. And certainly with some of our smaller funded programmes, we can't train health workers and build excellent health facilities and ensure that there's water and electricity. But for some of the key things that make it work, we're very flexible and open to working with our partners on what those recommendations are. And so, for example, in some of our smaller programmes that we work on with AMREF in East Africa, the greater proportion of the funding is actually on strengthening the health facility. There is no point in training health workers who don't have anything that they can draw on to deliver the services. So we try and tackle some of the root causes, and we're very flexible in the way that we do that. So hopefully that's addresses that question.
Thanks, Darryl. The question about what doesn't work, Fiona, you were asked as a kind of objective, neutral person to come and have a look at this programme. What did you find that you thought needed to be working better?
I mean, I think the issue of, the health worker, community health worker incentives, attrition, I think it is a big issue, and it's an issue that, as Darryl says, we continue to talk about, and in all different aspects of the health system and all different focused programmes. I mean, I think just to add to what Darryl was saying, I think this sort of issue of partnerships have been critical in this approach programme, and I think the government and the public sector partnerships are really vital here. So it's like it's building capacity, it's sort of informing, it's involving, it's involving a whole range of stakeholders in the design of the programs and approaches in the implementation to make sure that everybody's actually on the same page and it sort of works for everybody. I think in some of the projects, and I think maybe Svetlana can also talk more about that, I think there were some issues in sort of feelings of maybe that wasn't sufficient involvement, and some of the programs may have been going on their own own routes without sort of sufficient bilateral discussions. But I think in a way that those were sort of drawn in a bit and sort of discussions were taking place. So I think some of those were the challenges going forward. I think the environmental challenges persist in places like Afghanistan, where sort of security and sort of mobility and accessibility of especially the female community-based educators and midwives into areas of the community remains an issue, which in a way it's difficult, it's a sort of wider sort of approach is necessary, and sort of linking into the question about, what do you focus on? Is it infrastructure? Is it sort of water? Is it electricity? In a way, that's why we're sort of talking about the importance of these horizontal approaches and where the intersectoral approach is critical. And it's sort of, we can't have just, fantastic health infrastructure with no electricity. So we need to, it's somehow bringing together all these different sectors and ensuring different ministries are sort of involved in the discussions as well. And I think some of the projects in different countries have been doing that. I think there's been intersectoral approaches. I don't know, Svetlana, if you want to add something to that.
Thanks. Just because I'm going to come back to the people who just had their hands up a second ago, but as this big issue of compensating health workers has come up, maybe I'll just turn to both Dr. Jahangir and Cara. Just say a little bit about the model in Bangladesh you have, where the community skilled birth attendants are actually paid for their services by the patients, and how does that work? And any thoughts you have on that, Cara, because you're obviously concerned about, the right level of public versus out-of-pocket expenditure.
Yeah, no, actually, that's an just important question. And just when we design this project, there are some hypotheses in our mind, just in this remote Haur waterlogged area, just I personally visited, I see that the coag, they're earning kind of several £100 per month. And people are paying, even poor and other family, they are paying for the services. That's why out-of-pocket expenditure in Bangladesh is 64%. And anyway, people are paying to the informal and this kind of provider. And that kind of ignite us to think, okay, then because if we develop health worker and then rely on the government, sometimes government current health system, it's don't have enough financing to run all the part of it. So that's the practical situation in the developing country. And then we okay, that's the hypothesis. With this hypothesis, we started this project, and we thought, okay, if we can train community health worker, if they can provide quality services, and it is being recognized by the Ministry of Health, and they are very much well connected with the kind of community, and the community ownership is there, as because when I and we see that all the WHO lesson learned, the failure of the community health worker project is three. One is there is no community ownership, there is no finance planning, who is pay for them, and their quality of care is not being kind of monitored. So and we just, though it was challenging, but we try to address all these three, financing, we rely on the people, the community people, they will pay, and there will be a scheme at the local government level so that they can reimburse for the poorest of the poor. And quality of care and the training, the government will take that role, and the local government there also. And with all this, just when we implement it, we find that their current earning is kind of 4,000 Bangladeshi taka on an average, which is 35 pound. 45 pound is kind of benchmark. And it's just more than 1 year we have been implementing at the community level after all this training. So that it seems there is a kind of trend, positive trend, they are going to, may not be 100% of the worker, at least more than 80%, they will achieve their financial goal. So people, they want to pay if they provide quality services. And we need to have a kind of kind of very transparent mechanism of price determination and to monitor the equity issue. That's why the local government is there. But still, we are in the learning process, and we can come back again with more robust data. Thank you.
Thanks. Cara, do you want to add anything?
Yeah, just a couple of things, I guess. So, one is to have 64% of the resources for health coming from out-of-pocket payments. We know that that's going to be contributing to an enormous amount of impoverishing expenditures. And when we think about the little payments that are going to the community health workers, I think we do have to see those in the broader context. So it sounds unlikely that families are impoverished by the small payments, and actually the very poorest families, their payments are made by community organizations. But I think it is important to keep an eye on that overall problem. And if we look across countries, in order to get to very low levels of impoverishing health expenditures, payments need to fall to less than 30% of the total. So there's quite a long way to go. And so I think seeing these issues in that broader context is important. But the other, I think, point is you can improve relative affordability by making sure that what people are paying, they're getting a good quality service for. That's got to be an improvement. It may not be an improvement of the whole spectrum of improvements that are needed, but at least people are paying for services that are likely to be effective.
Okay, I want to make sure there's plenty of time for you to ask questions and get some answers, but I just thought that was a big issue, so it was worth hearing some perspectives on it. So we had Simon and then a few other, you, yeah, absolutely, and you came in first. Sorry, next time.
Thanks, Laurie. Simon Wright from Save the Children. We also benefit, as was said, from the GSK 20% reinvestment partnership. My question is really to keep going on this point and would like to ask Dr. Jangari a bit more about, exactly what Cara set out about if public financing and private provision can work if the public financing is sufficient and if the private provision is provided in a way that is ensuring universal health coverage. And that's really a challenge for NGOs if we start working with whether to work with for-profit private companies. And I just wonder if you could say more about what happens, how you make sure that this method of paying doesn't deter people or distort people's decisions about care seeking, because even if there's exemptions, those are very open to a lot of corruption and a lot of distortion. And also, if care workers have an incentive around their sale of products, that does lead to inappropriate use of products. It takes the decision of what products people should be using away from a purely medical decision. So I wonder what kind of safeguards you've tried to put in place for that.
Okay, thanks, Simon. And then this lady just in front of you, if you pass along.
Hi, I'm Jolene Scortis-Worrell from UCL. It's a general question to the panel because everyone's been using the word quality quite a lot this morning. And I know that the colleague from Options has mentioned some ways of measuring quality, but a lot of the statistics that we've been seeing have actually been talking about quantity, not quality. And we know that patients and service users themselves are quite poor judges of the quality of the services that they receive. So I'd really be keen to hear more about how quality of service deliveries is being monitored within these programs, particularly because, and this is the second part of the question, it's not clear to me to whom these service providers are accountable, especially when you've got a complex set of payment mechanisms happening and different users and contractors. Even in the UK, we've got question marks about accountability and transparency when you have contracting. So I think quality in a context of lack of accountability. Thank you.
And then one last question, lady in green here, and then we'll take some answers.
Thank you. My name is Sarah Dobson. I'm from Mott MacDonald. It's a very similar question to the one about quality, because that was what was in my mind. And I'd like to hear more from Fiona. You talked about the engagement with government and stakeholders at other levels and how important that was to this programme. But we didn't hear much about the next level of services and how everything that goes on at community, what the coordination is between to ensure that women who are referred get quality services at the next level up? Who's working at that level? How is JSK interact at that level? And then coming over to Jahangir, if you could say a little bit more about how you monitor the outcomes of, again, it was about numbers, and you talked about numbers of antenatal visits and also referrals, but how much do you look at the outcome of those referrals and how they were managed, and about actually morbidity and mortality as a result of the referrals?
Okay, thank you for those questions. Dr. Jahangir, maybe we'll come to you first, both with Simon's question about what impact on incentives for both the providers and the patients, and then the questions about measuring quality and accountability, and then we'll come over here.
Right. I think that just fixing or determining the service price for the private provider in most of the developing countries, it's a very sensitive issue, as because government, state, they declared, okay, everything is free, but their system is often not working. But they are kind of enjoying just telling everything is free, so that, and there is a kind of culture of blaming to the public sector providers, doctor, nurses, okay, we gave everything. So that's why, like, introducing any kind of price is it's a sensitive. The way we did it, like when we designed the project, there is a very specific, there is a kind of, we spent some time do some scoping exercise, and we have all this information from the Sunamganj districts, so most underserved, and healthcare, it's a huge absenteeism from the public provider and non-availability of the provider, and then hugely dominated by the non-formal private provider. People are paying. And when we share all this information to the Ministry of Health and all the stakeholders, and then, okay, just we need to develop local skill provider, then who will just pay for their services. Then there is a kind of common consensus that maybe community will pay if they can provide the service. Then the next question, who will determine, and how transparently it will be determined, and how it will be monitored. And then just there is a decision, okay, there is a local government chairman, as because local government, it's in Bangladesh it's called Inuan Porishod. So, and there is a number of community support system and support group who is participated by the poor, rich, and other elites. And then the decision is local government chairman, in participation of the community as well as the private provider and the Ministry of Health people, they will determine for each of the services, and that will be hanged everywhere in that community, and that will be with the Ministry of Health as well. So, and there will be just kind of maybe different kind of price for the different kind of services. So, and we applied that approach, and then we didn't face any big challenges for that, as because government accepted it, and that was determined by the government, and there is a kind of monitoring system. The question is like how these the poor, like whether who cannot pay. So there is a kind of mechanism, like one norms is there. If anybody seeks services, they need to provide the services. If they are unable to pay, then the PCSBA, this private provider, will inform local government and the community support group. They will find some mechanism. Like for instance, two sub-districts, there is a government scheme. It's called demand-side financing. And this provider, they are registered for the demand-side financing, and they are being reimbursed from the government some fund, and that's from different other scheme. But in other places, the local government and the community support group, they are kind of, they are reimbursing from them. And now Ministry of Health, they are kind of starting learning it. So how they can take it to the other places, because there are some local mechanism for this kind of pay for the services and monitored by the local government and the community support system. So quality maybe? And the quality is kind of, it's like, that's a good question, like how we are just monitoring the quality. So first we just put Ministry of Health in the driving seat to monitor the care quality, because care will not be there for a long time. So that's why just we developed a kind of some supervisor and providing training to them, and like the standard operational just procedure. So on each of the services we provided training, and they developed a kind of some checklist, and so that they are using it to see and observe and how they are kind of following it. That's kind of more provider perspective. But there is a kind of user perspective, like those who are receiving services, so they can, there is a kind of feedback mechanism for the community, to the community support system and to the local government, so that they can, when they meet in a monthly meeting, where they if any kind of PCs, their behavior is not good, and so somebody feels okay, they are charging more, instantly at the end of the month they get that kind of feedback and for rectification. So that's a kind of ongoing system. It's like monthly they are having that space to share the feedback, so that, and also like for the provider part, if they find that they are not confident on some kind of procedure, so there is a mechanism for refresher training at the sub-district level by the government, and project kind of support for that kind of training. So that's kind of more kind of quality of care part. So it's both part of your area. So
Fiona, a couple of questions directed at you there, if you want to respond.
I'll try, then I might hand over to my co-author to add to. So just in terms of the quality issue, just also to add to what Doctor was saying there, is in some, it's a very good question. I can't remember who asked it. It was a very good question. I suppose in Nepal, one way that also that they're doing it is through these community-based processes of the Community Health Scoreboard, which is sort of where I think you probably realise that the community develops a grading system, and then it's scored on a regular basis, working with the providers on that. And then also the other tool, which is monitoring the progress of the women in terms of the type of attention, medical attention they're getting. So in a way, it's monitoring maybe not the quality, but to make sure that they're getting it. So in a way, it's sort of possibly going towards there. And just to add, I think a lot of from a provider's perspective, a lot of the training that is done is following guidelines developed by the government and other sort of standards. So there's a sort of ensuring that the quality is maintained in that way. And also linked, you were talking about quality as well, sorry, I just remembered. Also in terms of sort of quality and also accountability, and as we've heard from Bangladesh, also a lot of these community-based agents are linked to the public health system. And so they do report there as well. And I think maybe that the field people would have more experience of how that is actually working in practice. But there seems to be quite a lot of effort placed on that to ensure that the public sector is aware of what's happening, and that they have sort of mechanisms for sort of supervision backwards and forwards. Again, the extent to which it would be interesting to hear about. In terms of the level of, your question is, in terms of the next level of service provision, how, so when women are referred upwards, I think your question was about that. So what's happening at that level? And that, I don't know, Svetlana, maybe you can respond to that question.
Right, just on them. So.
Yeah.
That's a good question. Like if you see the data, like at least 12% of the birth they attended referred to the higher facilities, and still there is a challenge, as because all the facility are not ready. However, and if we have the real impact on maternal death, then we need to be functioning EMOC center, emergency obstetric care center. So that's we know. And so that's why just still there is a challenging part, and we are working. The way we are working, like we mapping out all the facilities, both public, private, and NGO facilities, and also like know their just quality of care and all those things, how it is going on, and then we are giving just people the choice, so that they know like okay where they should go, where blood transfusion, C-section, everything is, rather than back and forth. And then, especially for the public sector, we are collaborating with kind of UNICEF, as because they have some project to strengthen EMOC facilities, so that we said, okay, there is a huge commodity mobilization is going on, there is a huge demand, and we put this local government in between as a influential, to make them accountable. Like, for example, if someone referred to some facility and they push to some private facility and they spend like maybe several £100 in a kind of a private facility, and that feedback came to the community, and then local chairman, they take that message to the public sector. Okay, just we referred the 3 people, but you pushed 1 people to the in the evening to the private clinic, and they need to sell out their all this household stuff and then take the services. So that kind of accountability mechanism is there. Public sector is still yet to be responsive fully, but we are giving them both option. Like there is some NGO, like USAID funded and ADB funded, there are some NGO clinics. They are also providing EMOC services.
Okay.
So that it's a kind of range of referral facility we are using and we are tracking.
Thank you. Do you want to add just briefly?
Yeah, I just wanted to add very briefly is that, to addition to what Dr. Jahangir said, is that we are developing really strong referral linkages, and for us, it's one of the major aims of this project. Is basically the way we look at it. It's not just about training the community health workers, but it's basically training health staff at different levels. So that also includes the formal, governmental health system stuff. So when the time does come where the patient needs to be referred to a higher level, let's say district hospital, those health staff are ready to help them in a timely manner. So for example, in Afghanistan, will give you kind of a model that we have developed. So we work with community health groups, the ones, as Dr. Jahangir, for example, was explaining, that actually identify the cases. But then we also train the community-based educators, and we're also training community-based midwives. And the midwives, interestingly enough, actually sit in the already existing clinics. So when the community-based educators identify some of the cases at the community level, they work together as one team with the community midwives, and they can refer them to the midwives. And then the midwives can make an informed decision whether they need to refer that case to tertiary services, depending on on complexity of the case. So I don't know if it came clearly in our presentations, is that it's actually not just the community health workers. We're working at different levels, so it becomes a very big comprehensive system of health services delivery.
Thank you, and that's Svetlana, who manages the programme for CARE in London. Daryl, do you want to just comment on this quality and accountability question?
Sure, yeah.
I'm going to take one last round of questions from people.
Okay, so yeah, great question about quality, actually. And I think what I tried to bring across a little bit in my presentation is that although we have an impressive set of numbers, so we can say we've invested this much and we've trained this many and we've reached that many, I consider those to be kind of input outputs, really. We input some money, we train some health workers, we reach some people, which is great. But I think what the long-term aspect of the programme really needs to address are outcomes and impact. And I think we started to show some of the outcomes of the programme here, the number of births that are taking place in a facility, and some of the impact, the changes in mortality and morbidity rates really start to tell you about the quality there. And I think the longer the programme comes on, the richer the data set that we have of those outcomes and impact. And I really use that to judge the quality of a programme that we have. And in order to make that happen, so of the funding that goes into a programme, I was saying around 40% goes into training, probably around 10 or so % goes into monitoring and evaluation. It's really important that we factor that in and that we hold to account, to an extent, those systems that we're building, so that we're clear on what they're actually doing. So that's really important. It's not monitoring and evaluation for GSK to hold on to. It's to build an external means of actually understanding what's happening. So as the projects have matured, in the 3 or 4 years that I've been doing this program, we've moved from having data about how much we spent to much more about what the impact is in terms of morbidity and mortality rates, which I think is really starting to tell you, and you can use that as a very strong proxy of the quality of care that happens. So we're very interested in that, and I personally regard that as in many ways more important than the headline stuff about how much money we've put into the programme. I think the other thing we just need to be mindful of is that we're working in very fragile health systems and the least developed countries. So I think it's important to consider where we've moved from. So in Bangladesh and in the communities that we're talking about, we're moving from situations where Births, a very high proportion of births are taking place at home, and if they are, it's with a traditional birth attendant who's had no training. So we're moving from a kind of a bit of a zero situation to one where we've got skilled birth attendants now. And I think as we evolve that, and as that builds in, and as we institutionalise some of that thinking, of course, the next point is the next issue is making sure that there are equality standards and that there's accountability that's developed and created and owned by the community and by the health system, the public health system that's there. But I think we need to consider where we come from here, really. And I agree that the community are not necessarily experts in public health, and the tools that have been developed by CARE, which have been embedded there, are not necessarily, they're only as strong as the people that are using them. But I think given that that didn't exist before, that's a huge jump. And I think over time, that will contribute to making sure that there's good accountability and an understanding of quality. So hopefully that kind of adds to the answers that have already been given.
Thank you, Daryl. So it's 12. So don't feel embarrassed if you really need to go to your next appointment. But I am going to. That's no problem. Thanks for your question. But I'm going to take one more round of questions, and if you can make the questions short, and we'll try and make the answers short, and then we'll wrap up. So there's a gentleman there with beard, for whom obviously I have positive prejudice, and then lady here, and Tom, and then I have a question from Lucy from Comic Relief Online, and then we will wrap up. So, gentlemen,
Stuart Britton, Health Prom.
Sorry, Health?
Health Prom.
Okay.
I wonder what the panel thinks of this. In our work in Afghanistan, standards are much more driven from the bottom than the top. The contracted provider of the health service is more concerned with staff being nominally in post, although some of those staff spend more than half their time in the city. But villagers, mostly illiterate, have got the idea that they have something called rights. And those rights don't grow out of the United Nations. Probably hardly any of them have ever heard of the United Nations. But still, that word is extremely full of meaning for women particularly who had never, ever had the idea that they had any rights at all, as they have no money at all. And villagers have started to get the idea that when they ride on a donkey, taking a sick child, for example, to a health centre, and find the health centre closed, they can do something about it. Now that is starting to drive standards. It's a slow process, but in a country where most health data, or a lot of it at least, is falsified, I think it is a much more sustainable method of progress than top-down, although both are needed.
Thank you. There was the lady there. Yeah.
Hi, I'm Olivia Tulloch. I work here at ODI as a research fellow in health. It's going back a little bit, a very basic question, but it's more about the actual model of these private, community-based skilled birth attendants. And I wanted to understand how, you mentioned that they do birth preparedness plans and that sort of thing, as you would. And I was wondering what they are promoting, like what do those birth preparedness plans entail? Are they still giving birth at home with those attendants or in some kind of private facility that's in the community? And I'm asking this because I work quite a lot in southern Ethiopia, where now health extension workers are being taken out of the equation in terms of delivery, and they're all really being pushed to be referred to health centres which are remote from their communities. So I just wanted to understand a little bit about what you're doing in Bangladesh and how it works.
Thank you. And Tom here, my colleague from CARE.
Hi, Tom Sessions from CARE-UK. So I work on private sector engagement at CARE, and top of mind for us at the moment really is thinking about the SDGs, as Cara was mentioning, being adopted next week in New York. And we heard from the Addis Financing for Development Conference that, you know, it's a shift from billions of pounds of aid to trillions of pounds of investment, and looking to the private sector for a lot of that. But I'm just interested in Dr. Jahangir's impression of, you know, these global goals that are set at such a macro level. We saw in Dr. Jahangir's slide about the MDG goal that was set for the Sylhet and Sumanganj district. What do you think the impact of these goals are, or could be, on incentivising, you know, public and private support?
Okay, thank you. And then the question from Lucy at Comment Relief was also for Dr. Jahangir, was what's the biggest challenge you've experienced, and what have you done with that? So I'll ask Dr. Jahangir to address those various questions first, and then I'll come back to each of the panel members for responses to those last questions and any last thoughts that you want to give, and then we'll wrap up, and I think there are some refreshments outside.
Yeah, regarding basically birth preparedness, this private health, private skilled birth attendant, they are supported by number of health workers and who just promote this birth preparedness. And birth preparedness include just to not only targeting the pregnant woman, their husband and the in-laws, and talking about like from where she need to take this antenatal care and where she will deliver its facility or at home. So discussing all the different options, and if there is any kind of, especially more emphasis on if there is any emergency, so what is the transportation and whether they are saving some money. So all the plan that they need to be there. So it's like, and that promoted by the community support group member as well as the health worker. And where they are kind of more just discuss, since the health facility is not nearby, so they kind of negotiate that, okay, they will call this skill provider who is trained and who is available there. So that's kind of right at home. At home, as because the area we are working, maybe in Bangladesh, like for example, just we are planning in future to go to the facility delivery. That is appropriate for some region, but the Sunamganj, so now just we are happy with if they are skilled birth delivery at home. So as because there is no facility ready there, so that would be the next kind of step. So that's at home, and that's part of the birth preparedness, like when, where, and by whom they will be delivered. So prepare them, and so that they can take kind of informed decision about it. And about this SDGs, yeah, just in Sunamganj we achieved MDG, 50% of delivery by the skilled birth attendant. But if we see that this is kind of entry like point for this kind of community, and we are developing this cadre, and we know that they are being trained and accredited by Nursing Council and OGSB. However, the long-term plan like that goes along with the universal health coverage, like the HDC, as because like this, there are huge missed opportunity. Like this cadre can be given some more skill, like they can do some, provide some more like the nutrition. They can dealing with the like immediate like this diagnosis for this diabetes, hypertension, and then they can refer. So that just we are thinking in future maybe they're adding some new services and integrating new services, and they're linked with some more facilities, so that they're one of the contributor to the universal health coverage. As because this community health worker, they will no more will be only with this dealing with this maternal and child health. That's because there are more need at the community level. And then in the next phase, we are also expanding how we can just meaningfully expanding some of their services so that they can integrate and they can provide it. So that's how you can link.
Maybe just in 140 characters, you can answer our online question. How are you dealing with your biggest challenge? Just one sentence. How are you dealing with your biggest challenge?
Yeah, actually the biggest challenge is more this remoteness, and whole system is not functioning there, and we are dealing as because we are getting huge kind of support from the government as because we took that challenge to go to the remotest area, and we are more involving local government and local community to just deal some of the challenges as because, and we get like very positive response from them as because they are, that is like this local government and the local community, they find there is a good opportunity for them so that they should capitalize it. So it's a more kind of win-win collaboration. Like there is a challenge, it's remoteness, it's not, nothing is just functioning there. It is very hard to get the right candidate for this skilled birth attendant, and then and we find that once they are motivated and once they see the tangible results, and they are more supportive to the during the process.
Thank you. Cara, any last thoughts from you or responses to those last questions?
I guess so. 2 points, and I think they're related. First, just I was interested by Simon's point about some of the risks of commercializing the activity of these private community health workers, and I think it's a risk because there is this potential for a great deal of what economists would call demand inducement, and to link forward then. I think I'm really excited by the universal health coverage target as an SDG. I think it's a tremendous thing around which to focus our efforts. And that really needs to be driven by a commitment to public funding for a basic package. If that basic package is being funded through private out-of-pocket payments, that's going to take us away from that goal of universal health coverage. So I think, I do think the SDGs, they can be a lot of talk at the global level, but I think we need to use that to encourage countries to respond, to gather evidence about what works, and to figure out how do we get from here with this sort of rather motley crowd of financing systems to one where people have access to services that are good quality services and they don't have to be impoverished by them.
Thank you. Fiona, did you want to respond to any of the last questions or give us a last thought?
Just a quick thought about the gentleman talking about Afghanistan, and I found his take, I don't know if it's still there, very encouraging to hear that actually women are beginning to understand, issues around rights, and they're sort of driving up the standards, and I think that's really encouraging to hear that. And I think that is sort of crucial model that is necessary in all countries, but obviously there needs to be some thought of how to build the public sector to respond to that as well. And I suppose, I think just to conclude, I think community involvement is critical and mobilisation is critical, but we need to think about how that can be played out at different levels and supported at different levels by different stakeholders, including, importantly, the public sector, government.
And Dal, last word to you.
So nothing particularly further to add to that. I think, as I said, it's not a perfect system, but I think you've got to consider where it's come from and where it's going to. I think we do need to think about ensuring that any entrepreneurial aspects that are added to health workers are done in a way that's managed and that there's a robust mechanism for understanding and ensuring that the right incentives are in place for and regulated actually for the way that happens. But I think the benefits outweigh the risks, actually. I think if you're going to try and build sustainability, you've got to be innovative and creative. And I think with the right kind of support around that, it can be done in the right way.
Okay, well, thank you very much. Thank you, everybody, for coming. Sorry for going a little bit over. If you still have questions that you wanted to ask, please do join us for some refreshments now, and you can grab any of the panellists or some of the other people who are here from CARE and GSK and ODI. Thanks also to our online audience. If you also want to still ask questions, you can obviously carry on doing that online or through Twitter, which is also true for all of you if you can't stay for refreshments, so please do that. Thank you to all of the panel for coming and sharing your perspectives with everybody. I think it was very, very interesting indeed. And we look forward to carrying on working with GSK on this very good programme and continue to share with you the lessons from that so that other people can also apply those in other things that they're also doing. So thank you very much.